Hello, everyone. I am Byeon at the Asan Medical Center, Seoul, Korea. Today, I will talk about endoscopic treatment of early gastric cancer. So let me start my talk today. What is a gastric cancer? This is the normal inside view of the stomach. Gastric cancer is a mass lesion that is composed of malignant cells in the stomach. Normal gastric mucosa develops into early gastric cancer, which progresses into advanced gastric cancer. Sometimes early gastric cancer may be preceded by a gastric adenoma, a precursor lesion of gastric cancer. Because gastric adenoma and very early gastric cancers are confined to the inside of gastric wall without distant metastasis, endoscopic resection can be performed for curative treatment of these lesions. In contrast, late-stage early gastric cancers and advanced cancers should be treated with surgery with or without chemotherapy. To understand the principle of endoscopic treatment of early gastric cancer, you should know the difference between early gastric cancers and advanced gastric cancers. Gastric wall is composed of 4 layers. The most inner layer is mucosa, and the second layer is submucosa. The third layer is the muscularis propria, and the most outer layer is subserosa. Early gastric cancer is a cancer which is confined to the first or second layer, that is mucosa or submucosa layer. Advanced gastric cancer is a cancer which grows up to the muscularis propria or deeper. The most important principles of treatment of early gastric cancer is complete removal of cancer from the human body. We can perform either endoscopic resection or surgery for complete removal of early gastric cancer. Endoscopic resection is easy and comfortable compared to the surgery. There is no surgery associated complications such as adhesion, reflux, dumping syndrome, malabsorption, and so on after endoscopic resection. Surgical scar is also absent, and hospital stay is short after endoscopic resection. Considering all these advantages, endoscopic resection looks better than surgery. Then, is endoscopic resection applicable to all early gastric cancers? To understand the indication of endoscopic resection, you should know the regional lymph node. This red area is an early cancer. Lymph node is a structure like a bus stop through which cancer cells metastasize to other organs of a patient. If cancer cells are confined to the gastric wall, endoscopic resection of the primary cancer here only can remove this cancer curatively. But if a cancer cells already involved a regional lymph node outside of the stomach, endoscopic resection of the primary cancer here only cannot remove all the cancer tissues from the patient because endoscopic resection cannot remove the regional lymph node, which is located outside the stomach. There are endoscopic and histopathological indications suggesting early gastric cancer without regional lymph node metastasis. They are differentiated adenocarcinoma, mucosal cancer without ulceration, 2 centimeter or smaller size in case of polypoid early gastric cancer, and 1 centimeter or smaller size in case of depressed early gastric cancer. Currently, progress of endoscopic technique and device is expanding the indications for endoscopy resection of early gastric cancer. So nowadays, larger early gastric cancers can be treated by endoscopic resection. Then, how can we predict the lymph node metastasis? Qualified, highly experienced endoscopists can predict the possibility of lymph node metastasis by endoscopic observation and endoscopic ultrasound observation. Radiological tests such as CT and MRI can be helpful in the prediction of regional lymph node metastasis. But the accuracy of regional lymph node metastasis assessment is not perfect, even though we use all these diagnostic modalities. If no lymph node metastasis is suggested by endoscopic and radiological tests, endoscopic resection can be performed. If lymph node metastasis is suspected based on endoscopic and radiological tests, surgery with lymph node dissection should be performed. Because the severity and stage of early gastric cancer correlate with the risk of lymph node metastasis, histological examination of the resected specimen should be performed to investigate the risk of lymph node metastasis more exactly. If no lymph node metastasis is suggested at the histological examination of endoscopically resected specimen, follow-up without further additional treatment can be performed. In contrast, if lymph node metastasis is suspected at the histological examination of endoscopic resection specimen, surgery should be performed to remove regional lymph node metastasis, even though the primary cancer was already removed by endoscopic resection. The most commonly used endoscopy resection technique is endoscopic submucosal dissection called ESD. The procedural steps of ESD is like these figures. So firstly, special fluid is injected into the submucosal layer. Then the submucosal layer just beneath the tumor, just beneath the early gastric cancer, is dissected by using various types of specialized endoscopic knives. Then the early cancer lesion is completely cut and resected. There is an early gastric cancer here. Mucosal cutting was performed after submucosal injection of special fluid. Submucosal dissection is being performed, and finally, the early gastric cancer lesion was completely removed by endoscopic submucosal dissection. ESD of early gastric cancer showed very good clinical outcomes if the indications were selected appropriately. Curative resection rate was 88 to 93%, annual local recurrence rate was only 1 to 2%. So the 5-year overall survival was 96 to 100%, and 5-year disease-free survival was 97 to 100%. Okay, now let's see several questions and answers about ESD of early gastric cancer. The first question is, how long is the ESD procedure time? The answer is, it depends on the size and location of early gastric cancer. Usually, ESD of early gastric cancer requires 1 to 2 hours. The second question is the gastric ESD safe? The answer is generally safe, although the bleeding complication occurs in about 7% and perforation occurs in 4 to 5%. However, most complications can be treated conservatively without surgery. Next question is, how long should I stay in hospital for gastric ESD? The answer is, you need to admit and stay in hospital for 3 to 7 days. The final question is, do I need any follow-up tests after ESD of early gastric cancer? The answer is yes. You should undergo regular follow-up tests, which include regular upper GI endoscopy to monitor local recurrence and metachronous early gastric cancer, and regular CT scans to monitor metastatic lesions. Okay, let me summarize my talk today. As I mentioned in another lecture about gastric cancer screening and diagnosis, you should start gastric cancer screening since the age of 40 years. Earlier start may be reasonable if you have symptoms and/or positive family history of gastric cancer. Upper GI endoscopy is the best modality for gastric cancer screening. Upper GI endoscopy should be performed every 1 to 2 year interval. If there is high risk for gastric cancer, shorter interval screening tests may be reasonable. Endoscopy resection can be performed for cure of early gastric cancers without regional lymph node metastasis, and endoscopic submucosal dissection, ESD, is the most commonly used endoscopic resection technique for cure of early gastric cancers. Okay, this is the end of my lecture today, and thank you so much for your kind attention.